Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. Good morning to our honorable guest, Dr. Noharna binti Muhammad Fazil, Deputy Medical Director 3, Head of Department Specialists, Medical Officers, and all respected HRPZ staff. I'm Nur Wahida from Medical Legal Unit, will be your MC today. Our speaker this morning is Dr. Benjamin Sajdev, Pakar Perubatan UB14 from Rheumatology Unit, Jabatan Perubatan HRPZ 2. This morning, we will be presenting on the topic of the hidden predator, early detection and diagnosis of lupus. Please welcome Dr. Benjamin.
Hello. You just take this. Okay. Okay, good morning, everyone. So today, I think on this very early morning, I'm going to be talking about something that's very close to my heart. My name is Benjamin. I'm from the Rheumatology Unit. So obviously, I think all of you probably would have heard of us. You have called, you've probably referred cases, you sent tests, and in the most recent, I think the past few months, or maybe 6 months or so, every time you want to send a special test called an ANDA, somebody has to pick up the phone to call us because reagent is not enough and things like that has been going on. So definitely all of you have seen us at some point of time. So I'm going to talk about a topic that's very close to my heart, and it's actually one of my areas of special interest, which is lupus, SLE. So I titled this thing as the hidden predator, early diagnosis and detection of lupus. And the aims for today is that we can educate each other so we can learn about lupus, how to recognize it. Because a lot of times these patients don't come straight to the rheumatology clinic. They can end up in the emergency department, in the primary health. Sometimes they end up in the surgical ward with acute abdomen, first. Sometimes they end up, with our nephrology colleagues with nephrotic syndrome. And so the way lupus presents is very, very diverse. And that's very, very important for us to know. So let me just see if this thing works. How come it doesn't work anymore? Okay, never mind. My pointer thing doesn't work anymore. I think it's because of the way it's put up. Never mind. Oh, tak boleh click. Ini pun tak boleh click. Oh, tak boleh cuba lagi. Okay, very good. Okay, sorry for technical problems. So I don't have any disclosures that's relevant to this talk. So the learning objectives, by the time you leave this hall in the next 30 minutes, you will have learned 4 points. So make sure you learn these 4 points. First of all, you must recognize the clinical heterogeneity of SLE and its mimics. Secondly, you understand a diagnostic and investigative approach to lupus. So if you suspect lupus, what should you do? The third thing, you understand some principles of management. I'm not asking you to give immunosuppressants, pulse steroids, but it's important to have an understanding of the principles of management because we sometimes share care of these patients together. The patients may come in for, example, a surgical procedure, but they also have underlying lupus or underlying rheumatoid arthritis or some underlying problems, right? Generally, they have a long list of underlying problems. So some principles of management, how do you monitor these patients? And finally, when and why you should refer to rheumatology. I always start off my talks by saying that if you're not sure, just refer. So it means you call us and then we can tell you whether it's indicated or not, whether we need to see the patient or not. That's very, very important. Because sometimes it's better to ask rather than to let it be until the patient becomes very unwell. So let's just put a bit of your thinking caps on because it's like 8 in the morning. I'm still trying to wake up myself. Okay, so what I want you to do is I want you to think silently, don't have to shout any answers. What would you do when you see this group of patients? These patients can present to the emergency department, can present to your wards or your medical clinics. So just think what you will do and we'll see what happens at the end. The first patient is this. She is a 26 years old lady. She presents with joint pain, swelling, both the wrists, hands, and some photosensitive rash, fatigue, and some mild alopecia. So I'm quite sure most of you would know what we are thinking about when we put this, very typical kind of history, right? And most of you will probably pick up the phone and call somebody and say, okay, I want to send an ANA. Or you have written a form and say, I want to send an ANA for this patient or some other test. But think of what would you do in that particular situation. In the second patient, 23 years old patient presenting with facial puffiness, bilateral leg edema for 2 weeks, frothy urine, fatigue, mild joint aches, and some high blood pressure. So the patient has got peripheral edema. This patient will probably have ended up in the emergency department, correct? Will have come into the emergency department, and then at that point of time you think, oh, give furosemide, give furosemide. But then you must ask yourself the question, why the patient at this young age is like that? The third patient is this, maybe something not so typical. 32 years old lady admitted with some new onset seizures and a history of intermittent headaches and cognitive dysfunction for 2 months. She has also a previous history of photosensitive rash. So that's the third patient. The fourth one is a 28 years old lady presenting with pallor, fatigue, dizziness for 3 weeks, jaundice, dark color urine, mild joint pain, and intermittent fever. So maybe if you saw the jaundice, then you will refer the patient to surgical abdomen. Thing is a stone. Could be, never know. But this is one of the presentations that we have today, and we will look into it after this. What should we do after that? The fifth patient is this, a 35 years old lady presents with persistent redness and flushing across the cheeks and nose for 6 months, exacerbated by heat, sunlight, food, stress. So she said when stressed, her face becomes a bit more red in color. You know, when she gets scolded, she gets, her face becomes a bit more red. Some occasional pustules, some small dilated blood vessels, but no other symptoms. So this is almost similar to the first patient, correct? Same kind of, presentation, but maybe with a bit more history. And so it comes down to what we do every day. When you come to work, the first thing that you do is you, of course, will put down your bag, go to your room, right? And then subsequently you go about and see your patients. And we do this same thing over and over again every day, whether it's in the emergency department, whether it's in the ophthalmology clinic, or whether, we're triaging patients anywhere. We go through these 3 steps: history, examination, and we think of what we're going to do next. Even if the patient is sitting down in the ward for very long, every morning you go through the patient, you ask them what happened yesterday, right? How did you feel overnight, correct? That's history. Then you proceed to examine them. And then in the morning, if you are if you like to send a lot of blood tests, then you become a vampire in the morning. You tell people, take 100 blood tests, and send for these things because you're suspecting something happened over the night. Or if you're not the kind that take a lot of blood tests, you say, oh, okay, we don't really need to go home, discharge, you're fine. But this is what we do every single day. And the aim of this inquiry is actually to establish a pattern and to actually decide what is going on with the patient. And as you become more senior in the service, I think if you're more junior, you probably get a bit more scared. A bit more senior, you can see like, for example, maybe our neurologist can come from far and see the hand, in one say, oh, that is a stroke, I see it from far. And so that's a pattern that we've come to establish and come to know. And so that is what we do every day. We ask history, do examination to try to see if the patient fits into a specific syndrome or specific problem. And that is what we do in order for us to come to a diagnosis. But it is very important to note that a lot of things overlap. And sometimes patients can present atypically, or they can present with typical symptoms but with a different diagnosis. So this map at the end actually has to be very flexible, enough to allow for us, to find out what is going on with the patients. And so that's something very important. So my overview today, we're going to talk about SLE. So that's my little charama about, history, examination, and investigations, because it is very important in the diagnosis of SLE. You cannot just diagnose SLE just based on the blood test. There's a lot of things to consider. And so today I'll walk you through it at a speed that hopefully you can appreciate and understand. So SLE, you must remember, is a chronic systemic autoimmune disease. So it is not a single organ. Usually, they present with constitutional symptoms, they present a whole host of things. But the problem is that they present at different time points. So what happens is that sometimes they can present a mala rash 2 years ago. And then later on, 1 year later, they came in for fever, cytopenia, which was admitted to medical ward and thought to be dengue. Then discharged home with the platelets so-called recovering in the white cells so-called recovering. 1 year later on, come in with sudden pedal edema. And that's the point that when we ask them when you were admitted, oh, you had dengue. Oh, the bloods never recovered, or they never went to the KK to check back their bloods again after that to see whether it recovered or not. Then when you put this all together, you say, oh goodness, this sounds like SLE. So this is a chronic systemic autoimmune disease. And the biggest problem that we face is that it has a very heterogeneous presentation. There is no typical kind of presentation, not like MI. Pain, or even MI also got a typical presentation, but the typical history of MI is that patient come in, left-sided chest pain, radiating to the left, very, very profuse sweating, gasping, breathing pain and things like that. Do ECG, got ST elevation, oh, MI, Unfortunately, with lupus and connective tissue disease, it's not that simple. So lupus has gone through a lot of things over the years, from what we call as the classical period, the neoclassical period, and also the modern period, where we have a lot of investigative tests. And this is where our laboratory is suffering a little bit. Because we send a lot of tests, and then they are like doing a lot of tests, and then when the tests come back, we have to interpret the tests. So this is where we are at this point of time. It affects a lot of people, about 3.4 million people worldwide, and about 400,000 individuals are diagnosed every year. And very interestingly, patients who are Chinese, patients who are Asian in nature, they tend to have worse SLE compared to others when they have done studies. And so this is why you see a lot of our patients having lupus nephritis, which is one of the worst outcomes of SLE. If you were to look at charts, very interestingly, we always think that they present young, but majority of the patient actually presents in their middle ages, about 50% of them, 30 to 50 years old. But they do present at extreme ages as well. When they present younger, they tend to do worse. They tend to have much more complications or much more manifestations. And so that's actually something quite important. And of course, with all autoimmune diseases, with the exception of a few, females always predominate compared to males. If we were to look at how severe they present, about 50% of them actually present with a mild symptom. So a lot of times the mild symptoms are not recognized well. And then as time progresses, they actually become wanted. And they actually become like moderate is wanted, and then severe is also wanted. And they follow a disease course that can be very good, meaning that one time kena something and then after that they become better. Or they can follow one where you did everything, you give steroids, you give all kinds of immunosuppressant, but they remain very active. So we have got this kind of disparity within their disease progression. If you were to look at the global incidence of lupus, it is prevalent in Asia. In Asians, it's about 30 to 50 per 100,000 person years. In Malaysia, we have our own study, which is similar, about 43 per 100,000 years. So these are the incidence and the prevalence of lupus. So what then contributes to lupus? So the next question my patients always ask me, what caused this? I'll be very frank to say that no one knows. We just know that a lot of things may cause it. There's associations with it. We do not know what causes lupus. So if we could find the cause, then we would modify that cause and no one would develop lupus, correct? But unfortunately, we do not have that at this point of time. So there are many factors that actually contribute to the development of SLE. Things like genetics, things like your hormones, that's why more likely females will get it, especially with estrogen. And of course, environmental factors. All these contribute towards the development of SLE. And if you were to look at these factors that modify SLE, this was actually a surprise to me when I was preparing these slides a while back. So sleep deprivation actually increases your risk of developing SLE. So how many of you here sleep deprived? Tidur lagi? Got a few people. So you should be careful. Your odds ratio is 2.9. 3 times the risk. So you should write to your head of department and say, I need to sleep more at night and get SLE. Tak boleh kan? The other things that actually really contribute, so sleep deprivation is one of them, but other things that really contribute towards the development of SLE will be things like UV radiation. So that's why we tell our patients not to go out. So if you get sunburned a lot, that's actually higher risk of getting lupus. Or smoking. Smoking actually causes so much of problems, right? I think everyone who smokes should just stop. I always tell my patients, you must keep on, you must stop. Other things that are very interesting would be things like silica exposure, endometriosis. So these patients tend to develop. But you must remember things like, OCP use, endometriosis, all of these things are a bit biased because predominantly affects females, right? So definitely these kind of risk factors will start to come up as time progresses. The pathogenesis of SLE, I'm not training you all to be rheumatologists, so you don't have to know the pictures that I'm going to show after this, but I just want you to understand a few key concepts. The first thing is that with all of these immune problems, there is an increase in autoantibody productions, meaning the antibodies that attack your cell. Okay, not good antibodies that attack other things, but antibodies that attack your cell. And so these autoantibodies will end up forming immune complexes and depositing on the end organs, ultimately causing damage towards those end organs, such as kidney damage, CNS damage, and things like that. If you were to think about the pathogenesis of SLE, you would think of this picture, which should be inside a museum. Because it looks very nice, like a picture, like somebody painted this picture. But all of these things that you see here, A, B, C, D, E, all of these are part of the pathogenesis. And so what I'm trying to say is this: SLE is characterized by a dysregulated immune response. That means our immune system regulates itself, homeostasis, remember all of these things, right? Similarly, our immune system regulates itself. But the problem is that SLE, the immune system is dysregulated, becomes a bit crazy. I always tell my patients, you say, kamu punya sistem pertahanan menjadi gila sikit. Dia menjadi sangat-sangat aktif sampai dia menembak diri sendiri, something like that. And what happens is that it involves both the adaptive and the innate immune system, and it leads to inflammation and organ damage. And this inflammation and organ damage ultimately manifests as things that what we see clinically. Malar rash, discoid rash, or if you do a renal biopsy and put on a microscope, we see all of the immune complexes that are deposited in the glomeruli. So this is the end organ damage that we have. If we were to take a biopsy of the skin, this is what you're going to see. It's very pretty, right? Very nice, kan nampak sangat cantik, but it's not something you want to have on yourself. So you can see the immune complexes actually depositing onto the skin. And in the glomeruli, you can see different types of antibodies, IgM, IgG, IgA, C1q, C3, which is part of the complement pathway. All of these things actually deposit onto the kidney. And these things actually constitute the damage that will happen after that. And so this is why you see the symptoms that you see. So the most important part of what I'm going to talk about is the clinical features today. All right, so all of this now already 10 minutes in, everyone wake up already, kan? So the moment the coffee started to work already. So just remember a few of these points. Number one, lupus can be visible. That means you can see. And this is the easiest. You see the malar rash, you see the discoid rash, then they come in with pancytopenia, and straight away you're thinking, okay, this is probably going to be lupus. But what happens is that a lot of times patients will present to our hematology colleagues, our nephrology colleagues, and they present with invisible symptoms. So things like IHA, things like glomerular nephritis, which shows all of these things on investigations that we usually cannot see with our naked eye. So this becomes the harder patients to diagnose because there's no malar rash, no oral ulcers. Then later on, when you call the rheumatologist, what they'll ask you, oh, you want to refer patient for IHA, got malar rash, got oral ulcer, got hair loss, got brain loss, oh, don't have, refer hematology. Then Dr. Aini will see the patient and then she'll say, hey, no, this is lupus, this is not, other things. But this is what we see because that is the problem. Not all of it comes at once. And so the presentations and manifestations of SLE vary. It can affect anything from the top of your head to the tip of your toes. I always tell patients that. And the problem is that its clinical course is always marked by flares, unpredictability, and damage. If you were to look at this over here, like looking at show you that with the pointer, but you see the red line right way up there. If the flares are allowed to continue, damage continues to accrue. And that is the problem that we see. At the end of their lives, our patients have a lot of damage physically. And that's that's something that we're trying to modify. Hence, I propose to you there's actually two challenges in SLE management. The first challenge is where all of you are at. The second challenge is where the rheumatologist is sitting down in the clinic and in the wards, scratching their head, trying to figure it out. First of all is diagnosis, and second of all is treatment in achieving remission. What we aim to do is that with these two challenges, with early diagnosis and treatment initiation, as well as when we achieve remission through the use of medications that we have a lot of now, and I'll show you a few in a bit, we aim to change this curve from one marked with a lot of flares and increasing damage to one that has little flares and little damage. And our patients should live as normal as possible with medications, not without medications. I always tell them that. So the first challenge, which is where we are at today, is in diagnosing SLE. And we know that a high index of suspicion is crucial. But if we think everything is SLE, we become paranoid. So we do not want to be paranoid. You must remember common things are still common, right? So if you see a patient who comes in with abdominal pain, think about acute abdominal causes first. Don't think of mesenteric vasculitis as your first diagnosis, correct? Betul? If a patient comes in with finger pain, and he just slammed the finger on the door, think of not arthritis, but think of fracture. Right? It's straightforward as that. But sometimes we need a bit of remembering because we always think of all the hi-fi diagnoses, and SLE, I would say, is the hi-fi diagnosis. But we always forget that common things are always common. But that being said, there's a lot of things that also can constitute SLE. Diagnostic delays is still common. And in fact, diagnostic delays can last up to about 63% of patients. And the reason is because the symptoms can come up, go down, wax and wane, and evolve, making diagnosis very, very difficult. It takes an average about 6 years from symptom onset towards diagnosis for some centers. But in centers with rheumatologists and access to treatment and access to investigation, it tends to be much faster. And we hope that we are picking up patients much earlier in their disease so we can modify their disease. The median number of healthcare visits before receiving a formal lupus diagnosis was 3, but the range is between 0 to more than 10. And so that is something that we're trying to improve on with all of this awareness. In Malaysia, there has been a study that was published talking about the delay in diagnosis. There was a retrospective post-hoc study that was done, and a lot of them, well, maybe 26%, so we're not so bad, not more than 50%, not 60%, but 26% of them had more than 6 months delay in diagnosis. And the factors that's associated with delay in diagnosis is unfortunately number one, older patients. And sometimes the older patients, because they come in with very non-specific complaints, or they don't complain at all, until one day their family sees them, why you are so unwell, and they bring them to the hospital. Secondly, in the absence of things that are very hard signs, so things like pancytopenia, alopecia, rashes, so these are things that contribute towards diagnostic delay. It often goes undiagnosed because the symptoms, as I mentioned earlier, can actually emerge quite gradually. And it mimics other disease. And before you can say something is contributed to lupus, you must do a lot of workup clinically with investigations and other things as well. And so there is a very high heterogeneous presentation. And there is the biggest problem is that there's no single diagnostic test. And that's actually something that that we're trying to work on as time progresses. When there is diagnosis delay, let me just put it on the left side, you will see there's a lot of damage and there's a lot of problems like end-stage renal disease, organ damage, and problems with medications. But on the other side, what happens is that a lot of patients will start saying that they feel unheard by clinicians because they keep on telling you, got pain here, pain there, but say, we don't really see anything. And then they feel that it erodes the trust that they have within the treating doctors. And this is when the patients start going doctor shopping. They start going round by round, one doctor to another, because they're looking for somebody to listen to them, for the person to understand them. There are many classification criteria, and I'm not asking you to memorize this. I'm just asking you to look at this and remember that the symptoms of SLE vary a lot. And all of this, together with an ANA that's positive, helps you to make a conclusion that the patient has got SLE. It has evolved over the years that we come to even recognize that you can have one organ limited, for example, like renal lupus. So sometimes what happens is that our nephrology colleagues will see the patients for nephrotic syndrome, do a biopsy, and it turns out to be SLE. Then retrospectively, they will send an ANA and then it'll be positive. And sometimes the ANA can also be negative in those situations. So sometimes in young patients with renal impairment and things like that, a lot of times the renal biopsy will be very helpful. We've also moved on to having a better classification criteria, trying to get rid of all the mimickers and things like that. And we have come up with this 2019 ACR classification criteria. And if you notice, it's very nicely put there: constitutional, hematologic, neuropsychiatric, mucocutaneous, all these things like that. But very important for you to note is the top. I always tell people this. The second line that says, if you can see from the back, do not count a criterion if there is a more likely explanation than SLE. So for example, what I told you earlier on, correct? You hit your hand on the door, it's not going to be due to lupus, right? Even though you have a bit of rash on your face. So things like that is very, very important for us to understand and to appreciate. What about biomarkers? Then you say, okay, now you say the symptoms also, you have to look at other things. So what I'm telling you is think of lupus, but don't think of lupus at the same time. I'm giving you all a very hard job, right? Then you are going to ask me, so then why can't I just send some blood tests and it's all done with? For example, heart failure, if I send a pro-BNP and the pro-BNP is like 1,000, I'm like, oh yes, patient has heart failure or something like that, right? But then now, you're telling me that, okay, it's not so straightforward, okay? And then secondly, we ask for a test. But unfortunately, there's really no single diagnostic test for SLE. And the reason is because a positive ANA, which is what we use for screening and for help in classifying the diagnosis, is not a lupus equivalent. Having a positive ANA does not mean you have lupus. It's sensitive, but not very specific. In some studies, ANAs can be found in normal, healthy people in some high titers. In lower titers, they tend to be more positive in much more of the population. Higher titers tends to be less. And ANAs also can be found in various other conditions, such as liver disease, malignancies, hematological conditions, skin disease, even psoriasis can have ANA that's positive. and infections. And the most common mimicker in Malaysia will be TB, right? So TB can cause NCAS to be positive, can cause ANAs to be positive. And in the wrong clinical context, you suddenly use steroids, high doses of steroids to a person with TB, oh, that will be asking for, trouble already. So you have to be quite certain and quite sure what you're dealing with. A positive ANA in rheumatology, when we see the patient, does not mean SLA as well, even though they have symptoms. Because if you think about it, an ANA positive with things like Raynaud's, puffy fingers, and they have got other red flag signs, and then when we do extractable nuclear antigen, SCL70 becomes positive, and then we do neophil capilloscopy because with systemic sclerosis rather than SLE. So not just normal other diseases, but also rheumatological diseases. So for me, evaluating an ANA result would be like this. If you see an ANA that's positive, because now we send a lot of ANAs, can. So ANA positive, number one, the first thing that I will ask the patient, the person who refer me is this: what was the clinical context that the ANA was sent in? What was the symptoms at that point of time? Not now, but why did you send it at that point? And secondly, I'll look at the titer, and then if a low titer versus a high titer. If a high titer, it does not mean diagnosis, but it makes us think a bit more. When we look at the pattern, we consider ENA results, and then we try to match the antibody to the clinical picture. So the ANA is positive, the SCL70 is positive, like just now I showed you, and then they have got Raynaud's phenomenon, then I'm thinking they more likely have got things like systemic sclerosis rather than SLE. So this is just a quick guide for you to know. And a positive ANA to me is never a problem. You can send out how many ANAs you want. You will send them to me, and I'll tell you, for me, it's not a problem. But what I have a problem with is a misinterpreted ANA. So a misinterpreted ANA in the wrong clinical context can become a big problem for patients. Because if we say they have lupus, we drill it into their mind, we start them on immunosuppressants, we may be masking the underlying problem. We've got patients who have ANA positive with pancytopenia turn out to be malignancy, hematological malignancy. And then they are precluded from the appropriate treatment, and that is very sad, actually. And so this is why it's very important. This one I will skip, but then just note that, as I mentioned, it can be ANA negative as well. So just remember, if you think of lupus, call us, let us see the patient. So the diagnosis of SLE remains one of the most challenging in medicine. At disease onset, about 50% of lupus patients do not meet the standard classification criteria. So we call it incomplete lupus or undifferentiated CDD and things like that. There is no single sign. I wish I could tell you the single sign. Every mala rash is going to be SLE. It's not going to be SLE. There are probably 5 or 6 differential diagnoses for mala rash. The diagnosis of SLE requires the presence of multi-organ involvement, with the exception sometimes kidney can present first, in the setting of immune dysfunction, the presence of antibodies. And how do we investigate them? We follow the signs and the presentation. My 4 steps towards diagnosing SLE will be this: start with your clinical suspicion, as I mentioned earlier on. Rule out differential diagnosis such as TB, infections, drug-induced, things like that. Investigate according to the system involvement, not just because your patient's SLE. Okay, so this is something I noticed recently. Because a patient has SLE, they qualify for an echo to look for pericardial effusion. It's not supposed to be that way. You're not looking for serositis just for the sake of looking for serositis. So that's something I always remind myself as well. So just because if they do not have symptoms, you don't need to do certain investigations. You do investigations as appropriate to what the patient is presenting in front of you. Then you send autoantibodies in the right clinical context. You investigate according to the organ system involvement. So if they have got neurological, then you do the neurological exam. So that's why I think, rheumatology is very nice if you're interested in doing rheumatology. Rheumatology is like general medicine on steroids. So we take steroids and become more super a bit. And of course, we give a lot of steroids at the same time as well. So general medicine, first, think about how you would investigate an appropriate approach the patient, and then subsequently you get your diagnosis from there. So you integrate what you see, you don't isolate, you don't interpret things in isolation. There's no single diagnostic test. So what you do is you let the clinical presentation guide your testing, not the other way around. You don't use a test to guide your clinical presentation. You let the clinical presentation guide your testing, and the workup should be systematic, organ-directed, and contextual for what you're seeing in front of you. If there is a suspicion, please refer the patient. Don't wait for the ANA to come out. You can send the ANA, but if you really think this patient has SLE, vasculitis, or something like that, call us. We will see, because we have treated patients for less. We've seen the clinical features. We don't wait for the ANA. We treat them first, especially if they're in a life-threatening situation. because waiting for the test will probably be detrimental. So as I mentioned, manifestations as compatible, SLE-related autoantibodies, and differential diagnosis such as mimicus, we have to exclude them. So going back to our patients. So this first patient ended up having a ANA that's positive, a DSA is positive, and then so this is a malar rash. So this is SLE. Okay, all can appreciate typical picture. This patient came in subsequently, came in noted 24-hour urinary 2.5, ANA was positive, DSA is positive, complements were low. So we're thinking this patient has got SLE with a renal manifestation, and this patient should qualify for renal biopsy in the correct clinical context. The third patient, of course, has new onset seizures, and everything was negative, everything was fairly okay, but DSA was positive, ANA positive, complements were low, MRI showed that there was one specific white matter pattern. So this is probably first neuropsychiatric presentation of lupus. Lumbar puncture was normal, other things were negative. The fourth one, patient pallor, fatigue, dizziness, we all thought, they say maybe cholecystitis or something unlikely, right? So patient has got autoimmune hemolytic anemia with ANAs as positive, the complements are low, LDH is raised, so all of these things will be indicative of lupus. The final patient, everything else was normal. Ultimately, this patient has got rosacea. So the patient has got rosacea. So, all understand so far? Very clear? Yeah, so basically I tell you take history, do examination, send the correct test, and don't kena marah by me lah. That's basically what I'm saying lah. Okay. Finally, the challenges. So the challenges, this I'll just put it, is quite quick. The most important thing is regular screening for organ involvement, and this is what the rheumatologist will do. SLE is why I harp on this so much is because SLE is associated with a lot of problems and increased in mortality risk. I'm going to show you something, maybe it will shock you, maybe it won't. Okay. But if you were to look at all our SLE patients, this is their odds ratio from dying for certain things. Things like infections and renal disease is still number one. And secondly, death due to cardiovascular disease. And this is unfortunately the end for some of our patients who do not do so well. So just remember that there's a lot of complications that can actually occur. I have done a few studies in this area. So one of this is my SLE cohort study that we have. And we find that infections were actually the most common cause of admission. So this is why, as a rheumatologist, every time people refer me, I always ask them the first question, is it an infection? And then people will say, no, it's not infection. No, patient spiking fever away, Because you must remember, these patients are on heavy immunosuppression. They are not going to present typically. You have to remember that they are immunosuppressed, immunocompromised. And so infections is actually the most common cause of mortality in our group of patients. As in ICU, the most common cause of death from my cohort was infection. Nothing else. Just infection. Culture-proven infections. So it is something that is very important for us to take care of. So, okay, that's the very sad part. So now I go back to more happy things. Regular monitoring is very, very essential. Things like the manifestation. So you ask history, do examination, and take blood. So basically the same thing, history, examination, investigations each time. How you do it clinically, laboratorically, imaging, and then how often when they're active, every 1 to 3 monthly. Sometimes we see them weekly or so if we are very concerned about them. And in stable diseases, every 6 to 12 months. Some of my patients see us once a year, and they are doing fantastic with just hydroxychloroquine in the background. We have changed our management, and in fact, if you look at management from steroids all the way on to current management, we have got so many new things, so many new toys to play with, so-called medications, but they're very, very expensive. And so steroids is still the mainstay of management. We have come to understand SLE very well. We don't know what causes it, but we know what happens when it happens. And so because of that, we have got a lot of targeted therapies now, like B-cell therapies, we've got JAK inhibitors for some conditions, we've got so much of things in our armament now. Interferon, treatments and things like that. And all of this is so that we can modify the natural history with early diagnosis, which is our job together, and treatment, which is the rheumatologist and the general medicine doctor's job. So we hope that with all of that, our patients can become better. When we consider treating patients with SLE, we consider what we see in front of us. If we see a renal disease, we treat them as per the renal disease. If we see a lot of joint pains and malar rash and things like that, we treat the skin. If we see the the blood, hemolyzing away with thrombocytopenia, we treat that. And our aim is to find one drug or one gun that can hit everything. so that we can treat the patient effectively with the least amount of medications and toxicities. And the treatment generally depends on severity. What you can do in the wards or when you see patients with lupus is remind them of these few things. Number one, educate them on their disease. Because when they do not know what's happening to them, they become scared and they become fearful. And when they become scared and fearful, they will not want to face the reality of what's going on. And they run away. And that's where our defaults actually come in. I have one paper that is pending publication end of the year or next year, where we have done a systematic review on non-compliance in lupus patients. We found that in all of these studies, 60% of patients are non-compliant. So that is a very staggering big number. I think for diabetes, it's probably even higher. Maybe for your other departments, it's even higher. But 60% means that 60% of them are not taking the medications as prescribed. Medications that can stop them from having damage and medications that can stop them from progressing to things like end-stage renal disease. So education is important. Smoking cessation is very important because it makes things worse. Things like physical exercise, we encourage them to exercise, but don't do it under the hot tengah hari sun lah. Do it in appropriate settings, wear sunblock and things like that. So photo protection also is something very important. Can give them some SPF 50. We have got a lot of guidelines. I won't go through this because this is beyond all of us, but just note that we have so many medications available now for non-renal and for renal SLE. And on the topic of renal SLE, this is something that's even more passionate about. Identifying lupus nephritis is very, very important. So if you see an SLE patient with some form of renal disease, please let us know and let our nephrology colleagues know. Because repeated episodes of lupus nephritis, if you look at the end over there, one episode of lupus nephritis is more than enough for any of our patients. One time having a flare for their kidney is more than enough. Because each time they flare their kidney, they lose nephrons, and the nephrons do not regenerate. The nephrons will hypertrophy, and then the nephrons will end up overworking. That's where your proteinuria comes in, and they end up going to end-stage renal disease. And there's a paper that I didn't put in here that actually showed that the end-stage renal disease, we improved with our treatment, so the curve actually went down. But in the 2000s onwards, after cyclophosphamide was given and things like that, even with new therapies, it plateaued the percentage of end-stage renal disease for patients. So whenever they have got renal impairment, I always say, hit hard, make sure you do it fast, don't wait. Because the longer you wait, the more damage they have. Imagine this is a 20-year-old girl, 25-year-old person, who has got another 30 or 90 years of their life to live. If we plan to live until they're 100, right? So they've got so many more years where the kidney needs to function. Okay? If they have got CKD, they are at increased risk of cardiovascular disease, infections, and kidney failure. That's what we know of. And this is just to show you that lupus nephritis is nephron loss, hypertrophy, and becoming CKD, and ultimately end-stage renal disease. And with that, we have also changed our approach to SLE management with lupus nephritis. We not only say give immunosuppressants, but we do things that we do in diabetes, give ACE inhibitors, monitor the blood pressure, make sure all of these things are optimized, this so-called non-immune phenomenon of lupus nephritis, in order for us to achieve remission and to help the patients. And patients who are very refractory, of course, we have got advanced therapies, and we've got something very exciting, which is things like CAR-T. So CAR-T is being used in hematology, and of course, stem cell transplants. We have got, I think overseas, there are a lot of case reports that are very good. That means you cure the lupus. But of course, you have to go through very, very significant amount of stress and problems before that happens. Cardiovascular risk management, as I mentioned, manage the lipids, manage the sugar, manage the blood pressure. All of this is very, very important. And finally, this is the last slide of mine. I would just like to say, okay, we have 40 minutes on the dot. So this lady is a lady who's going to present to all of us in the emergency department in the clinic, 29-year-old lady. She presents with high-grade fever. She has SLE before on low-dose immunosuppression and fatigue generalized malaise, and she's got bilateral ankle tenderness and things like that, and some chest x-ray that showed that there was some reduced entry. Did some tests. White cell count is not significantly raised. Platelets about 200. HP is 10.2, CRP is elevated 120. Other things are quite okay. Chest X-ray shows that there's an infiltrate. So all of us know in this kind of condition what we will do: admit the patient, start antibiotics, treat the patient according to an infection. But then this question always gets asked to me: how do I know which patient has a flare and which patient has an infection? Could be a flare. We never know, joint pains, things like that, right? Fever can also be part of lupus, right? So I always tell people this: always ask them what were their initial manifestations. That's why if you look at our rheumatology notes, you'll see that SLE diagnosed when cumulative manifestations A, B, C, D, E, F, G, and then after that we write our management there, something like that. If you have ever opened our notes, if you tak pernah buka our notes, it's okay, don't worry. But what happens is that the A, B, C, D, E, F, G will tell us what the patient had before. And this will be the things we ask the patient. Do you have this? 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 Or is it something new that has appeared suddenly? So that will help us to guide us. Secondly, blood tests can help us as well. Clinical context, if they've got consolidation, you're going to treat for infection. But let's just say this just actually was clear. What can you do? So there are some things, there's a paper that was published. This is not standard, I guess, but this is a paper that was published. They had 40 SLE patients as well as some healthy controls. And they actually use things like the neutrophil lymphocyte ratio, ESR-CRP ratio, as well as the procalcitonin. And the procalcitonin cut off, right, in order for them to diagnose an infection. So if the procalcitonin is high, right, the odds ratio is 224. So that's why we send procalcitonin for our patients. But the cutoff that they use is not the standard cutoff that we use. The cutoff was 0.9. So if you see a procalcitonin that's elevated, it does not need to be the 2.0 and above. It can be 0.9 and above in the correct clinical context. Remember, all the tests is always in the correct clinical context. And if you look at the and all of these things, they find that if the neutrophil lymphocyte ratio is more than 2, CRP more than 6, ESR-CRP ratio less than 2, or PCT more than 0.9, these are things that kind of help you to think that the patient has got some form of infection ongoing in the background. So, last slide, in conclusion, you see the wolf there with the sheep clothing, right? So hopefully now you can take off the sheep clothing and you can see the wolf already, which is the SLE. Effective management of SLE requires this: early recognition, timely intervention, tailored therapy, continuous patient engagement, and multidisciplinary collaboration. Rheumatologists don't work in isolation. We catch out every single person inside the room. We will call you and ask you to come and help us to look at this. You know, if abdomen, we ask surgical or gastro. You know, if neuro, we ask neuromed to help us, because our patients are so diverse and they've got so many presentations. A lot of times we need a lot of input, but what we do as rheumatologists is that we take all of this input, put it together, and decide on the next management step for the patient. And so finally, constant vigilance from progression and complications is very important in our SLE patients. With that, thank you very much. Okay, so
We now open the floor for questions.
do you have any questions you want to ask? Any burning question that you want to ask? Okay, I ended on time, 40 minutes. Yes.
Very good presentation. Tengok presentation tadi lah. It sounds similar also like of rheumatoid arthritis and also psoriasis. I look that as part of the diagnosis if it clarifies rheumatoid arthritis and psoriasis.
Okay, so I think the question is that how do you kind of differentiate between all of this? Because in patients that have got rheumatoid arthritis, they also present with joint pain, joint swelling, and things like that. Or psoriasis, they also present with joint pain, joint swelling. But I think one of the things that happens is that when we see patients, when they present, generally patients who have got rheumatoid arthritis and psoriatic arthritis, these are more inflammatory arthritis. They do not tend to affect other organs too much. For example, the brain, the skin. Skin, of course, psoriasis you can affect, but generally they have psoriatic lesions. They will not have the typical kind of like lupus lesions that we have. They generally also do not affect blood and do not affect the kidney. So those are how we can differentiate them to try to put them out together. Sometimes what happens is that in the initial presentation, patients actually present, I think the main thing is that patients will present joint pain. That becomes very, very difficult for us, especially if they're joint pain if nothing else. So that is for me where what happens is that usually what happens is that we get referrals like this, patient with inflammatory arthritis referred to our clinic, then we say, oh, okay, sounds like rheumatoid arthritis, if you come to our clinic, you'll see. But when we see them the first time, we take a full history. So meaning that we say, okay, yes, joint pain, we accept that this is inflammatory joint pain, right? Polyarthritis or whatever. And then we'll say, okay, you have this, you have Raynaud's, you have eye symptoms, you have things like that. So we ask features for psoriasis, like things like skin lesions and all. And then we check, we ask them to have other things like alopecia, you know, and other things related to lupus. And then from there, once we got all of this history, we examine the patient. We'll find if there's anything hidden anywhere else. I know like psoriasis can hide in the belly button, can hide in other places. We try to see. If we don't see any symptoms suggestive of lupus or psoriasis at that point of time, then we'll put the patient down as rheumatoid arthritis first. That being said, as time progresses, as I mentioned, they may develop more symptoms. So the treatment, the great thing about rheumatology is this: the treatment all the same. Whatever you do, right? With the exception of a few things, but generally, if you see joint swelling and joint pain, even with SLE, even if they're ANA positive and we think it's SLE, we give them methotrexate, which is the same as what we give for rheumatoid arthritis and psoriasis. So rheumatology is not so hard actually. But the key thing is that we watch them carefully for development of new symptoms. Sometimes in the beginning, it's quite hard to make that distinction, and it becomes more apparent as time progresses. But that being said, if we saw the same patient like joint pain, no rashes, but we saw there's kidney involvement, some proteinuria and things like that, or somebody's had any will turn out to be positive, then we will tend to think more of lupus rather than just rheumatoid arthritis as well. That's common. Hopefully that answers your question. Yeah. Yeah, it is quite puzzling. It's something that requires a lot of finesse in that sense. You have to take a very good history and then the examination. Then usually we'll put down our initial diagnosis, and most of the time it's quite apparent. Things like rheumatoid arthritis tend to be symmetrical, polyarticular, and they tend to be female as well. But they will not have pressure, they will not have any other organ damage as time progresses. But SLE will tend to have other things in the background. So we look at the full blood count, things like lymphopenia, leukopenias, and things like that, which should not occur with rheumatoid arthritis. Psoriasis, of course, is its own spectrum. Psoriasis has got psoriatic lesions, they can have uveitis, eye, inflammatory back pain, enthesitis. So all of these things we will ask them. So if they don't have any of that, it's less likely to be psoriatic. If you get what I mean.
Between SLE and rheumatoid, which is more common?
Rheumatoid arthritis, I think, will be still more common. So the most common inflammatory arthritis is gout. Okay, but among the immune problems, generally rheumatoid arthritis is one of the more common things that we have. SLE will probably be one of the probably one of the second commonest thing that we see. Rheumatoid arthritis, SLE. Okay. Any other questions before I ask you all questions? Oh, yes. Sorry, I can't hear. SLE in pregnancy.
Dr. Jenny, how do we pick up SLE in pregnancy?
Okay, that's a very good question. So SLE in pregnancy, it will depend. Generally, pregnancy goes uneventfully. Okay. Most of the time, when it comes to pregnancy-related lupus, it comes because of the urine FeNO. A lot of times they will say the urine FeNO, rarely because of the rashes and because if they have rashes and all, it will be quite apparent and quite easy to diagnose. A lot of times it's the renal involvement that gets us a bit, confused. So what happens is that as they progress throughout their pregnancy, I'm not an obstetrician, but then as they progress throughout their pregnancy, they start to develop this heavy proteinuria and things that are not typical of the typical preeclampsia that they have. Unfortunately, it is quite difficult to make a diagnosis during a pregnancy. So what we do is we treat what we see in front of us, and then later on, when they actually postpartum or whatever it is, then we will reevaluate them back. I usually tell people not to send ANAs during pregnancy because it tends to be positive anyway, and that's where the clinical context becomes very important. So if you see, for example, a patient of frank hematoproteinuria, like glomerular nephritis, not the typical, like the preeclampsia kind of thing, got IHA, and you do not think that this is things like HELP because it was too early in the pregnancy. Then you would think of things like lupus and other things like that. Ideally, a renal biopsy will always be helpful, but no one's going to renal biopsy a pregnant lady, I think, right? At such an early stage, at such a late stage. But sometimes early on in the pregnancy, if it's really indicated, I think it is possible, but that is in consultation and multidisciplinary team discussion with the nephrologist and us. But if they got typical malar rash, complements tend to be a bit more, in between. They got malar rash, they got proteinuria, they got joint swelling, joint pain, yeah, then fair enough, you can label them as SLE. It really depends on what we see at that point of time. But the one that's very hard to diagnose is usually the kidney one, because a lot of things can cause the kidney kidney issues, for example, preeclampsia and other things like that. So those are the differential diagnoses. But we keep it in mind and monitor them. Okay. Okay. Any others? Oh, my boss Natanya That's even scarier. Kalau my boss tanya soalan tak boleh jawab.
Good job, not bad. I just want to make a comment about the pregnancy. So that's the reason why for SME, they tend to be young lady. So we are very concerned when a young come to us. So most of them will tell them that the boyfriend ke belum. They will be blushing kan. Dan I kata, bukan minta you ajak I pergi majlis kahwin dulu. Semuanya I takut you kahwin and tak cakap kat I and bila you get pregnant, there'll be problem. So basically, we always tell them, kalau you dah ada boyfriend ataupun dah bertunang or nak kahwin, bring your partner to this to us also. Because we understand. And of course, we want them to be in stable disease. And one of the most important thing is that all the blood tests done for them. Basically, the immune markers. So especially so the anti-RO, because we want to look for neonatal purpose. So we want to send the antiphospholipid screening because there will be a risk of thrombosis and serum uric acid baseline because we actually puzzle between preeclampsia and also lupus nephritis with SLE. So we want to know the baseline serum uric acid. So those were the tests that were very important for all of us to send prior to the pregnancy. And of course, prior to pregnancy, advice most of them is education. Once they are pregnant, then they take their pregnancy goes smoothly. The only problem is when they were diagnosed very SME during pregnancy. That's the first presentation. That is when, like what Dr. Ben says, that we wait for them, we monitor along the way, wait them to deliver, and we will see again.
Any others? Okay.
Okay.
We can ask the 3 questions already. Okay, very good. So now I ask you all 3 questions. Go other price can something like that. Okay. So how will they answer?
Just raise your hand.
Okay, so raise hand and then she will pick, so I'm not biased. Okay. Okay. The 3 questions are very straightforward. If you dengar, then should be quite easy lah. Okay, the first question. Low titer ANAs can be found in normal healthy people. Kena angkat tangan untuk jawab untuk dapat prize. Sudah ada dekat sana. So answer? Yes, okay, very good. Yes, betul, okay. So I put this up there because I want to remind you that ANAs can be positive in normal people as well. So don't be too worried. But when you see it, remember to follow up the patients and to screen them for any involvement. Sometimes it can be like that. Someone with all the tests we send to Path Lab, Lab Link, all these things some things come back positive. We also don't know what to do sometimes. Okay. Question 3. Question 2 is after this. Pelik sangat saya punya. Okay lah, whatever lah. Question 3. Which gender is most commonly affected by SLE? Male, female, equal in both, or children only? Oh, dekat sana dah.
Assalamualaikum dan salam sejahtera.
Female, okay, correct. Very good. Okay, give her a hand, female. So just remember, female population.
September.
Wait for this to finish. And the last question, kena fikir sikit. There's a bonus question.
Polisi serta prosedur hospital dan memberi kerjasama penuh sepanjang penilaian kejayaan.
Yeah, I open the thing first. Which of the following is false? A. SLE is a multisystemic disorder with a potential to affect all organs in the body. A person must have a positive ANA to diagnose SLE. Hydroxychloroquine should be started in all patients with lupus. Patients with SLE face an elevated mortality rate due to infection and kidney disease. Which one of the following is not true? Over there. Which one? B. Okay, good. A person must have a positive ANA diagnosis SLE. Sometimes the ANA can be negative. And so this is why when we rely too much on the blood testing and antibodies, we will miss patients, especially patients with kidney diseases. So the kidney ones tend to have ANA that's going to be negative at some times. Okay, so with that, we have ended our talk today. Thank you very much for your time and for your attention this morning.
Thank you, Dr. Benjamin, for such a comprehensive session on lupus. I would now like to invite Dr. Izami Mendes, our hospital director, to deliver the certificate of appreciation. Thank you again, Dr. Benjamin. With that, we have come to the end of today's CME session. Next week will be Medical Legal Unit and Adwork to present more medical legal awareness. And thank you to all. Assalamualaikum.
Thank you, thank you. Have you? I've seen my head.